Hello, everyone. This is George Molina. I want to thank everyone for joining us tonight. I'm an assistant professor of surgery at Harvard Medical School, a surgical oncologist at Brigham Women's Hospital, and at Dana-Farber Cancer Institute. My clinical practice focuses on hepatopancreatibiliary and gastric cancers, and my research is focused on health systems innovation and health services research in surgical oncology. I'm also a proud member of the Latino Surgical Society, and I want to give you a warm welcome and thank you all for joining us today. As many of you might know, the Latino Surgical Society was established to cultivate, nurture, and support the advancement of Latino surgeons, and today's event is in line with this mission. We want to thank all of our institutional members who have supported our society, and also all the faculty and trainees at those institutions. Lastly, we want to thank you all for taking the time to join us tonight. I want to thank our members, our friends, allies for supporting and believing in a Latino Surgical Society. If you have not done so yet, I would highly encourage you to visit our website and become an official member today. Tonight, I welcome you to the second installment of our new series, where we highlight the experiences of residents who have matched into competitive fellowships. We hope that this event will offer our audience some wisdom and guidance that you can hopefully take into your own practice. Today's installment, we'll talk with 4 future surgical oncologists, and I will go ahead and start introducing them. Madeline Torres. Dr. Torres is a complex general surgical oncology fellow at the University of Texas MD Anderson. Dr. Torres immigrated from El Salvador with her mother and brother when she was 9 years old. She received a bachelor's in science and chemistry from the University of Colorado at Denver, and her MD from the University of Utah School of Medicine. She then completed a general surgery residency at Penn State Milton S. Hershey Medical Center. And during residency, she completed a 2-year surgical oncology research fellowship at the NCI in Bethesda, Maryland, where she developed novel murine models for neuroblastoma and CAR T-cell therapies for neuroblastoma and other solid tumors. Her research interests include CAR T-cell and other immunotherapy for sarcoma and other solid tumors, and the development of novel targets and biomarkers for sarcoma. Dr. Torres is also an advocate for equitable parental leave, policy in surgery, diversity and equity. She is passionate about surgical education, mentorship, and sponsorship. And her most recent project involved keeping her 10-month-old baby alive, who you can see now. Beautiful Giovanni.
Thanks for having me.
Next is Dr. Ricardo Bello Bocardo, or it might be Bello Bocardo. He's a complex general surgical oncology fellow at the Medical College of Wisconsin in Milwaukee. He studied medicine in his home country, Venezuela, at the Universidad Central de Venezuela, followed by a master's in public health at the London School of Hygiene and Tropical Medicine, with a concentration in health services research. When he arrived to the US, he completed a postdoctoral research fellowship in the Department of Plastic and Reconstructive Surgery at Johns Hopkins University. He then started general surgery residency at Johns Hopkins as a preliminary resident for 2 years, and then went on to complete the next 3 years at the University of Massachusetts in Worcester, Massachusetts. His interests include health service research, surgical education, and HPV surgical oncology. As a Venezuelan immigrant, Dr. Bello is passionate about bridging healthcare disparities in cancer screening and treatment. Welcome.
Thanks for inviting me.
And is it Bello or Bello?
It's Bello for sure.
Bello for sure. Yeah, excellent, great. Next up is Dr. Natalia Páez Arango. She's a surgical oncologist at Trihealth Cancer Institute in Cincinnati, Ohio. Natalia is originally from Bogota, Colombia. She completed a fellowship in complex surgical oncology at the University of Texas MD Anderson Cancer Center. Prior to that, she completed her general surgery training at the University of Louisville. She specializes in robotic hepatobiliary surgery, and her research interests include colorectal liver metastasis, neuroendocrine tumors, and disease of the pancreas. Welcome.
Hi, thank you, everybody.
Next up is Dr. Emanuel Eguia. He's a complex general surgical oncology fellow at the Memorial Sloan Kettering Cancer Center in New York City. Dr. Eguia completed his general surgery residency at Loyola University Medical Center, Chicago. While in residency, he completed the NIH T32 Research Fellowship at Loyola University of Chicago Health Science Burn and Shock Trauma Research Institute. His research focused on healthcare disparities, quality improvement, and policy evaluation in surgery. He also received an MS at Loyola University of Chicago in clinical research methods and epidemiology. He received his MD and MHA from the University of Washington School of Medicine and the University of Washington School of Public Health in Seattle. Dr. Eguia completed his undergraduate education in cellular molecular and also developmental biology at the University of Washington. His interests include gastrointestinal and hepatopancreatic surgical oncology, healthcare disparities, quality improvement, and healthcare policy evaluation. He's a first-generation physician born to immigrant parents from Mexico. Dr. Eguia is passionate about improving oncologic care for patients from underserved communities. In addition, he enjoys reading, running, spending time with his wife, Mary, and 2 daughters, Olivia and Naomi. Welcome, Dr. Eguia.
Yeah, thank you for having me.
And last, we have Roberto Vidri, who was born and raised in El Salvador. He left his country and obtained a bachelor's in science and medical doctorate in San Jose, Costa Rica, at the Universidad de Ciencias Médicas. He subsequently completed general surgery training at Brown University in Providence, Rhode Island. After finishing residency, he worked as a community general surgeon in Maine for 4 years and obtained an MPH in epidemiology at the T.H. Chan School of Public Health at Harvard. He was then recruited to Fox Chase Cancer Center in Philadelphia, where he was the inaugural Surgical Oncology Research Fellow. Currently, he's completing a fellowship in general complex surgical oncology at the University of Wisconsin in Madison. He has a particular interest in studying cancer outcomes across a wide variety of diseases. He uses large data sets to examine trends in treatment and disparities in access and implementation of care. These studies inform policy change and future trials to improve cancer care. Furthermore, he has a passion for data management and analysis and believes in the development of efficient data sets to answer the needs of contemporary surgical research. Welcome.
Thank you.
So as you can see, we have an esteemed panel from across the US and really from across Latin America. And I hope you all will really enjoy this session tonight. All right, so we have all of our panelists up. And Dr. Alexandra Hernández, who will be moderating the session, has joined us. Let me go ahead and introduce her. She is a third-year general surgery resident at the University of Miami, Jackson Health System in Miami, Florida. She's a Cuban Miami native, and she attended medical school at the University of Miami Miller School of Medicine. She's currently in her first year of research, working as an NIH T32 funded postdoctoral scholar in surgical oncology. Her research focuses on socioeconomic disadvantage and its influence on tumor biology and breast cancer. She's interested in a career in academic medicine in the field of surgical oncology. Dr. Hernández, please take it away.
Thank you so much, Dr. Molina, for the introduction, and thank you to our panelists for being here. So we can get started with the questions. To begin, can each of you share why you chose surgical oncology?
Sure, I'll start. So it's a combination of the biology, the disease biology. It's fascinating, in addition to the ability to take care of patients at a vulnerable point in their lives and be able to provide treatment, not only a cure, but also palliation, and the ability to actually care for them for a prolonged period of time. So kind of all of that together.
Just following the same order. Like Dr. Torres, I am very interested in the long-term follow-up that you can have in that relationship with patients. I did general surgery knowing that I wanted to do surgical oncology. And that's because it's, as the most medical of the surgical specialties, I really felt like my mentors that I had in surgical oncology were the ones that thought more like I did.
I'll go next. I went into surgical oncology because the patient population is completely different. It's so different taking care of cancer patients, and it's just so rewarding in so many different aspects, as well as the surgical cases and the technical. It's the whole picture it's what drew me to it. And I wanted to do surgeon since intern year of general surgery.
I'll go next. Yeah, so kind of like everybody said, I think a couple of things that really fascinated me about surgical oncology. I think one was really the patient population. I felt like some of the most grateful people I've met in all of surgery were the ones when I was doing my surgical oncology rotation, and even just now in fellowship. I think to be able to develop a lasting relationship kind of in a vulnerable point of their lives. And I think too, what really I like about surgical oncology is, the ability to work with multiple teams. You're not the only one that makes the decision. It really is a group of people, radiation oncology, medical oncology. And I think just that teamwork and being able to really take care of one patient is really what I enjoy about the specialty.
I will share a lot of the same ideas, but for me, it was initially the technical aspect. I fell in love with a neck dissection as a medical student, and at that point, just decided that's what I wanted to do for the rest of my life. I can't say I do many neck dissections anymore, but yeah. And then I share the relationship with patients and their families, and how grateful the patients are for everything. I think makes them a special group of people that we deal with every day, and they'll just take all the care that we can provide for what can be, a short or a long life ahead of them.
Thank you so much for those answers. That's really interesting and inspiring. So since we're sowing success for future surgical oncologists, and we heard about some of the amazing research that you are all doing, did you do research before applying to surgical oncology? And if so, in what areas?
Sorry, it takes me a little bit to mute the toys here. So I did 2 years of research at the NIH. I really wanted to go back to the bench, so I decided to do basic science. Everybody has a different path, and then I focused my work on immunotherapy, which is something I was interested in. I think the majority of us, as everybody stated, do research. What I would say to anybody interested is do something that you're passionate about, because it makes it worth it, rather than picking a topic. Pick something you're passionate about, pick a good mentor. That goes a long way.
For me, it's a little bit of a non-traditional research pathway. When I came to the US, I wasn't very smart about it and I didn't have my steps done. So I had to take time to do the steps, and I didn't want to do a course. So then I found a research fellowship that thankfully was funded. And the research fellowship was in plastic surgery. So I just spoke with my mentors and I said, I want to be a surgical oncologist. They found as many projects as they could in between the two of us. I think it's always important to be able to demonstrate that you're interested in contributing to the literature and being someone that's willing to write and think about the scientific method in general. That being said, I did not have one surgical oncology paper when I applied for fellowship, and that made me very nervous. I'm very grateful that my fellowship was okay with that. I don't know how common that is.
I did 2 years of research. I did a T32 fellowship during residency. So I did my residency in Louisville, but I did my research fellowship at MD Anderson in between my 3rd and 4th year of residency. So the T32 fellowship is an NIH-funded program that multiple academic institutions offer. So I think that's a great option for residents who would like to do research and may not necessarily want to, maybe they want to explore other programs. I was interested in MD Anderson, and that program is wonderful. But I know MSK and other places, IU, offer T32 fellowships. Mine was basic science. So it was pure bench work in the lab with investigational therapeutics. It was breast cancer research, really. And now I'm a GI, hepatobiliary surgeon, but basic science research can apply to any other. So it applies to the fund of knowledge that you get. So it doesn't necessarily need to be into something that you want to go into eventually, but at least to be a skill that you're interested in learning or having broader experience.
Yeah, kind of piggy off on that. I went into NIH, T32 position as well. I actually ended up doing it in trauma, and really the reason I did that was the mentor and the opportunities that were available there. You know, I wasn't even sure what I was going to go into. You know, I went into the lab after second year, but I was really interested in informatics, you know, machine learning, big data, and one of my big mentors, you know, had a big lab in that, and I wanted to be kind of under his tutelage, and so I ended up doing research with him for a couple of years, and kind of learned a set of skills, and you know, to kind of use that as a springboard to then do research later on in surgical oncology. But I think it's, you know, what everybody else has said, you know, do the type of research you're interested in. Don't just do it to match into a certain position, you know, because it really can be a lifelong kind of springboard to what you want to end up doing in the future. And, you know, those 2 years I spent in the lab, I had a lot of fun. And I think it really is like, kind of like I said, a springboard for what I want to do in the future. So, so yeah, that's kind of what I did.
So I'm probably the least traditional of the bunch over here. In residency, I was not offered the opportunity to take a couple of years to do research. It was just something that happened. So I was on a visa. I had to get rid of my visa. So I decided to just do a visa waiver right after residency. And moving to Maine, I was connected with the Department of Surgical Oncology at Maine Med, and just said, hey, I'm here. I want to start, you know, doing research and publishing. And they were nice enough that we started becoming very productive. During that time, I decided to do my MPH in epidemiology and biostatistics at Harvard. And I think that's something I would encourage many who want to do clinical and or disparities research, anything, that just having the research methods, the biostatistics, being completely independent. And that was kind of a springboard. Once I had that skill set, really publishing becomes easy because all you need is data. And once you have data, you can just start publishing papers. I have to say I had already matched into my clinical fellowship. And between the match and starting, I took a year to do clinical research, clinical and disparities research at Fox Chase, which was a brand new program. I was actually the inaugural research fellow for the Department of Clinical Oncology, but now it is a T32 funded 1 or 2 year program. So if people are interested, they also have a surgical oncology clinical research fellowship.
Thank you for sharing that. It's great to hear how many different avenues that all of you took to get to where you are now, and that, you know, it doesn't always have to be in surgical oncology research for you to get there in the end. So continuing on with being a competitive applicant by having research, and on the theme of having good mentors as well, when and what steps did you take beyond research to prepare yourself for a competitive application in surgical oncology? Oh, and this time we can maybe go backwards so that we're not going in the same order this time. If you want to start, Dr. Vidri.
Sure, thank you. I think there's a couple of things that stand out in kind of my path. Number one is I cannot underemphasize the importance of networking and having people that you know and will push you in, especially in such a small group as a surgical oncology. Having mentors that are willing to, you know, attach your name to an application and emails is probably the most important thing you can do for yourself. Having said that, just working really hard, showing that you're willing to put in the work and be more than just, you know, a general surgeon and be in love with what you do and research. I think it's a whole package. It is a very competitive fellowship. And you just have to at least rise to that package of having done research, having published, having demonstrated that you're willing to do that. But I would say having mentors and people who are willing to back you up is probably one of the most important things.
Yeah, I agree. I think, you know, mentorship is key to, you know, I think the success of all of us. I mean, at least for myself, you know, I think, you know, a lot of us maybe who go into medicine, you know, don't have, you know, initially maybe our families or parents or people who get us into these specialties. And, you know, you have to find those mentors and those people who will really be your sponsors. I think I found that early on, you know, in my residency. people who were really going to back me up, kind of like Roberto was saying, in writing letters of recommendation for me, giving me opportunities to participate in, certain activities to be able to, maybe boost my application. But I think, it's hard to say, what makes a competitive application. I think it's really your passion and wanting to go to surgical oncology, obviously your research. But something that I found even going through the interview trail was, really having a plan of what you want to do with your career and being able to articulate that clearly, I think is really key. And whatever that is, if you want to be an academic surgeon, then great, or if you want to go back to your community and be a surgical oncologist. But I think having at least some idea of what your plan is, whether, how you're going to make that happen is really what people want to hear. But that was just kind of my experience. So.
Yeah, I think what Emanuel just said about knowing what you want is one of the key. It sounds very obvious, but it not everybody is as focused as you would think. And so, for instance, when I was in fellowship, I was always involved in the process of interviewing applicants and in the ranking meetings for MD Anderson. And it's interesting because all applicants are very different. Some people may have more publications, but maybe others have fewer that are basic science versus more clinical publications. Some others may have other type of experience with global medicine, rotations. Others have other types of networking where they've worked very hard in certain institutions and have impressive letters of recommendation. So working hard, always being the first one to arrive, the last one to leave, knowing exactly what you want and being laser focused about where you want to go. It's something that opens avenues, because once you know exactly, hey, I want to do clinical trials, I want to work in this type of academic setting, I want to do gastric cancer, just being laser focused, I think helps a lot more than being a little bit more vague and not knowing, well, I want to do surgical oncology, but specifically, how do you want to do it? What do you want to do out of that? I think that radiates, and it's a lot easier to find mentors and to find the pathways and avenues. Knowing exactly where you want to go, it's a lot easier to get there.
Couldn't agree more about the importance of mentors in refining those answers in the interview trail. I didn't have good answers, and I was fortunate to have very strong mentors inside and outside of surgical oncology. When we started having these conversations early on, BJY3, I didn't even know if I wanted surgical oncology versus HPV, because then when I came into residency, I saw, oh, some surgical oncologists do only HPV. So even having that discussion of which program should I apply to, what should I look for in the programs, and what are these types of programs going to serve me best at, and where would I fit better? That was extremely important, and I tried rotating in between my mentors so I wouldn't annoy them too much. But I had a good, healthy number, especially being lucky from having been to 2 different programs. That was pretty fortunate for me, because then I had 2 sources of mentors. There's a paper out there, I couldn't find it when I was looking for it, about what program directors look for in surgical oncology applications. There's something about the app site. The more I thought about the app site in being an important determinant for making it into fellowship or not, the worse I did. I did better the years that I didn't think about it. But it is important to have scores, and the number it's supposed to be an average of percent of 50th. But right now, looking at people who are applying into my program, it's pretty amazing the absolute scores that people are getting. So obviously, it's another important number that should be attached to publication records and mentors and letters from rec.
So I'm going to echo what everybody said. The only thing I will add is the importance of being well-rounded. It's, you want to not just be your basic scientist and things like that. The importance of networking and being involved. Pick an organization, a professional organization that you're aligned goals with, and get involved. I spent a lot of time working with the American College of Surgeons and RAS and AWS because I believed in their goals. And that allowed me to network a lot with folks. So it created a network of people that I could reach out to and that I ran into along the path. And I think that significantly helps. So if you're able to also work on that front, I think it benefits a lot, especially if you come from a a place that may not have a big surgical oncology program, it really goes a long way.
Thank you so much for those answers. It's good to hear a different answer from each of you, but also echoing the same things of mentoring, working hard, getting good outside scores. And then Dr. Páez and Dr. Bello kind of segued into our last question perfectly, which is about the application and interview process. So this is our last question before we take questions from the audience. So what are some tips that you guys can share for the actual application to surgical oncology and interviewing for surgical oncology? This time we can go forward if Dr. Torres wants to start.
Would love to, thank you. You know, I will say be genuine in your application. So definitely do the research. You have to check the boxes to a certain extent, just with everything, right? So we'll try to put the papers in the chat, but if you look by WAC, et al. Is a paper that came out of the NIH that looked at what program directors are looking for. So obviously publications, abstract scores are not that they're important, but not that important, to be honest. Letters of recommendation go a long way. So make sure that whoever you get letters from, that you actually work with these folks and these folks know you. Extracurriculars, and then clinical. So you can be a fantastic researcher, but if you're not a good clinician and a good surgeon, you know, people won't vouch for you. So you have to be able to work hard and take care of patients, because ultimately that's what we all do. We take care of patients. And, you know, I want my colleagues to be solid clinically at the end of the day.
Those were great tips, and I wish I had done all those things. I just got really lucky. For me, I would say it's a grown-up application compared to the previous application when we were all applying for intern year. It's not worth it to play the game and try to like morph into whoever they want. Just being yourself and seeing where you fit, I think, is the most important thing. I felt the conversations were way more mature when I interviewed, and just knowing what I want and what they have to offer and what I have to offer to them. I think unlike residency, I think the fit of a fellowship is way more important. Very small programs, and these are going to be our mentors for the rest of our careers. For residency, I got lucky too, but I think the finding fit here was a little bit more purposeful for me because I had already gone through residency and I knew myself a little bit better.
So I would say that there are two aspects. One is the actual application that gets you the interview. And then the other one is actually after you get the interview and getting through the interview. Being yourself and knowing what you want matters the most, because even people who have perfect applications, if the interview, if they don't seem genuine, if they don't know what they want, or then it completely offsets a really good application. So I think you need to be very well grounded, well balanced into being yourself, knowing what you want. I think that's the key.
Yeah, I mean, I completely agree with that. I think it goes back to, like, what I said earlier. I think, for your application, I mean, obviously there's a lot of tips, obviously start early. Obviously there's, research that you have to do, letters of recommendation. It takes a couple months to make that application happen. So start early. I think, as you get ready for the interview process, it kind of goes back to really, like I said, having like at least an idea of what you want to do with your life. Because I think the most common question they're going to ask you is, what do you want to do? And it's very broad. And if you don't have a good answer for that, it doesn't come off genuine. It doesn't come off as, you have a plan for what, you want to do in your career, research. And so I think, take some time to, journal or write that down. Like, what is it really that you want for your career? It's not what your mentors want for you. It's not what, people tell you should be doing, but what are you really passionate? Because I think that really does come across in your interview.
Yeah, I agree. It's one is your CV, and I think everyone that gets an interview is sort of at the same level, right? Everyone's done research, everyone's been very successful, everyone's probably the best in their class or one of the best. Adding to what everyone else has said is showing that, and having been part of also rank meetings at my institution, that you will fit in that fellowship program is very important. It's something that's always discussed. It's your personality, how you interact with your interviewers. You know, are you gonna do well there for 2 years? And that's something that sometimes is just a matter of fit. But I would say, adding to what Dr. Páez said is that passion and being able to show that you know what you want, even if that changes later in your career, you have to at least be able to verbalize and say, this is my plan for the next 5 years. And for most of us, what we wanted to do and what we're going to end up doing is different. But you have to have a plan in place.
Thank you so much. Now I'm going to go to Dr. Molina to make some final comments before we take some questions from the audience.
I think this has been really fantastic. I did my fellowship at the Dana-Farber Mass General Brigham program, and the only comments that I would add is that what I have found being now on the faculty side, interviewing and ranking applicants, some programs have an issue with the fact that applying to surgical oncology, you do it as a PGY4, and a lot of surgical oncology services are PGY5 services or PGY4 services, but you haven't done it by the time you get your application in, got your letters, and you're actually interviewing. So one thing that my program did was that there were 3 of us that were applying to general surgery from MGH in my class. So it's PGY4s. The first 3 months we did our surgical oncology service. It is traditionally a PGY5 service, but we did it as PGY4s. So we can get, we know the attendings, but we hadn't worked with them in the OR. So if you can somehow talk to your program director and say, hey, listen, I'm applying to surgical oncology. Could I get some time, right, with our surgical oncology service? Because it's those attendings that we as faculty will call, right? And we'll say, hey, is this person the real thing, right? What do you think about this person? This letter was a little iffy here, tell me more. And some of those folks that we trust, right, our colleagues or people that we know that we see at the conference trail, they may not really know you as well because I've been operating with you, right? So I think getting that time, that FaceTime or time is important. So if you can do that, it would be great. It's not make or break. So don't stress if you can't do it, but I think it helps. And then the second thing that I would say is kind of echoing what everybody has said, I believe in having a story, right? Like you have to be a good storyteller. That's kind of one of the unfortunate parts of medicine and research, right? You can be the smartest person in the world, you can do some amazing science, but if you cannot tell a good story or write about it, it's hard to get published. It's hard to come across as like, you're really passionate. So work on your story, right? Why have you done what you have done, right? Tell me how all the dots connect. You were interested in trauma surgery, right? And you did all this trauma research. Well, tell me what skills you're going to take from that and bring it on to surgical oncology. Some of the best applicants have not published a lot in surgical oncology, but they published a lot in something else, right? So walk us through what happened, what are the skills that you learned, and how are you going to apply it to your future as a surgical oncologist. And then last, I would say some of the programs, at least when I was applying, and I think I saw this at MD Anderson and MSK, they will ask you clinical questions, but they sometimes will ask you, tell me about an interesting surgical oncology case you have seen, right? And they'll want you to walk them through that, right? I don't know if this is still the thing, but it was a thing when I applied in person. So my advice to applicants is have 1 or 2 cases that you have seen and you know what the workup is, right? Imaging, labs, right? Diagnosis, multidisciplinary approach, surgery, neoadjuvant chemotherapy, adjuvant chemotherapy, the operation, everything, right? Just have 2 cases that you can work on, during residency, during PGY4 year that you really know from like front to, from front to back, clinical trials, and know a lot about it. So you can just talk about it very casually. So those would be my 3 pieces, but this has been fantastic. Thank you all. I'll turn it back to you, Dr. Hernández.
Of course. Thank you so much for that, Dr. Molina. It was a great summary in addition to what we've already been talking about. So I have some questions from the audience. Natalia Correa asks, how do you handle the emotional challenge of delivering difficult diagnoses or prognoses to patients?
I'll jump in. It takes practice, and it does. You get. I don't want to say you get used to it, but you learn how to deliver news in a certain way, and it certainly takes a lot of training. Um, I honestly allow myself to just be human, and I think that's part of the reason I enjoy surgical oncology. I connect with the families, and I sit down with them, and I grieve with them. I recently had a patient who, unfortunately, we had to discharge on hospice, and it was hard. And I grieved with them. I was grateful, and I thanked them for the ability to take care of them. And then I go home and kind of, I have my support system and just let myself grieve. I found that if I kind of just bottle things up, it gets harder. So in a way you get used to it, but you learn to deal with it and you learn to grieve with the families. And I think allowing yourself to do that just makes the job a little bit easier.
Yeah, I agree with that too. I mean, I think, even in, not just even like in fellowship, I think during residency, I think of like when you do your trauma rotation and you have all these, situations where people are dying and you have to you're the first one to tell, family. And I think kind of like Madeline saying, like, really being there with the family, being present, being human. And the same thing I've found now in fellowship too, when you have to give difficult news to patients, I think just, treating them as, you would want to be treated, and really being there and comforting them, sitting with them and spending time to really walk through them with difficult situations. I think if you do that, it helps you stay human and not just, kind of take it as another thing that you have to do. And so, but I don't know, I guess that's what helps.
And I'm gonna jump in. I used 2 weeks of my med-onc month in fellowship and actually spent it with the palliative care team. And there is actually a science to the madness of delivering bad news and talking to people. There's a lot of work behind it. So that's, if you guys can spend some time with the palliative care team, it's actually very enriching.
Thank you, guys. So for the next question, this one's directed at Dr. Bello, but so you can answer first and anyone else can contribute. But this goes back to what you were talking about the fellowship fit. And Natalie Rodriguez asks if you can expand on why fellowship program fit is even more important than a general surgery residency fit, and how do you get that sense of fit in a Zoom era?
I'm sorry, I'm having some connection issues, and the AT&T tech support person this afternoon said, from what I'm seeing, I'm surprised you have any internet at all. So if I break off, I'm sorry. I would say in residency, there's always going to be people that you can fit in with and work well with. And if there's someone that, like you don't get along well with, it's not the end of the world, because there's so many attendings and there's so many residents. I think it's a little bit easier to have that natural organic fit and finding mentors. In fellowship, there's no escaping these people. You have to make sure that you really like all of them, and they like you, and that you think the same way and you care about the same things. I think it would be terrible, because for the next 30 years, I'm going to do everything that I do, trying to think of my main mentors. So I think it's extremely important to pick them very carefully, getting the best sense of culture from calling different people, not only from the interview.
I think for fellowship, it's also a little bit different, because when you're applying and interviewing for fellowships, you're also asking, what can that fellowship program do for you? So what do you want to get out of that fellowship program? So I think that's where the fit comes into play, where what kind of career do you want to have? What kind of practice do you want to have? So if you have to remember, you're also interviewing them to see what can they do for you.
Absolutely. Any more comments on that before we jump to another question? So here's a question from Leslie Diaz. She's asking, can you talk about work-life balance as a surgical resident and how that changes when you start your fellowship? And then I'd like to add to that how that changes as you become a young attending.
I can start, I guess. I don't know. I think in and residency is, you're doing a bunch of rotations in a lot of different areas that you may or may not be as interested in. I have really loved fellowship a lot. I mean, here the way our fellowship runs is under an apprenticeship model. So, when your attending's working, you're working, and so it kind of gives you that kind of lifestyle that your attending is going to have in the future. I'm sure they do a lot more paperwork than what we're seeing as fellows, but I found that the workload may be maybe a little less, but you're doing exactly what you're interested in, and I guess it just depends on where you do your fellowship, but it is also a lot of work, and I think, but it's like doing what you enjoy, and so I don't know, it's kind of a better lifestyle, I think, than residency was.
I'll chime in a little bit. So I'm not a big fan of the work-life balance way. I think it's more of a work-life integration and priorities. And certain programs are MD Anderson has been wonderful, very family friendly. And I agree with what has been said, that you work, it's better than residency in a sense, but you still work very hard. Obviously, you work as much as the attendings do, sometimes a little bit more. You have a little bit more control over your schedule, and the rotations sometimes are a little bit lighter, so you have a little bit more flexibility. And it gives you a better insight into what your schedule as an attending is going to be. So you use your time more wisely. But I think it's also very program dependent, based on kind of what the resources are available and based on the call system and everything. So that's something to keep in mind, as well as you look into things and you interview. And obviously, depending on what specialties you go into, if you're more of a soft tissue melanoma breast person who, a lot of the cases are outpatient, the lifestyle is obviously a little bit better or friendlier than, someone who does Whipples all the time. So that's also something else to keep in mind.
I would say, as a young attending, it's different. You have more control of your schedule. You get to pick when you do your surgeries, when you do your clinic, that type of thing. But you also have to keep in mind that now these patients, they're yours. So when you go home, you are looking at labs, you're answering phone calls. If you get results, if there's an emergency, if somebody's not feeling well, then that's your responsibility. So it does change a little bit. You have a little bit more control, but at the same time, there's a lot of more of your personal time that's being put into as well.
Absolutely. Thanks so much for that. So we have a question from Samantha Redden. How do you best approach somebody that you're interested as a future mentor? So we've talked about the importance of mentorship.
So I can tell you a story from when I was a medical student and I wanted to go into surgery, and I didn't know my mentor, I didn't know the surgeons very well in my program. So I just went online and I looked up, and the chair was this random guy called Kelly McMasters, who is kind of a big surgical oncology guy, but I didn't know that at the time. So I just emailed him because what do I have to lose? I'm going to email the guy, see what happens. And then you realize that everybody loves to teach what they have. They like to show what they know. I would say most surgeons love having somebody around to show them, to see what they do. So one is, don't be afraid to email or to ask and say, hey, can I see what you do? It can be as simple as that. And that email completely changed how I look at surgical oncology and how I move forward. So it's as simple as just asking.
I'll add something out of my experience. The mentor is not only in the professional side. It's not only someone that has you write papers and do work. It's actually who actually wants to see you succeed and will be able to push you. And I made the mistake as a resident of choosing one wrong mentor at some point, just because he was in the Surg Onc department and I wanted to be like him, but he was not invested in me. And that is something that we have to think about, is one is what they do professionally, and two, are they going to be invested in and want to see you succeed in what you want to succeed.
That's really good. Thanks for that. This other question comes from an anonymous attendee, and I'll add a little bit to it. But essentially talking about the different subspecialties of surgical oncology. So surgical oncology is a pretty broad field and now more focused on subspecialization. And how do you find your niche in surgical oncology?
I can start as someone that doesn't have an answer for that. As fellows, we're constantly being told not to find a niche too much, because when we're looking for a job, we're supposed to say, well, I'm interested in abdominal surgical oncology. You will see that some programs are more HPV heavy, some of them are more melanoma sarcoma heavy, but even the programs themselves are trying to round themselves up a little bit better. So I don't think finding a niche is too important at this stage. One of the most interesting pieces of advice that I'm planning on using in the future is trying to find something that is it makes you very passionate, that is very complex and is very challenging, but also having something else that you find very comfortable. So some people that do very big surgeries and then you notice that they're doing smaller surgeries on the side too. I think that's just one of those ways of finding a little bit of a balance and having a little bit more flexibility. I think another piece of great advice is looking at the fellow groups in each one of the programs, because they have their own like subspecialties in caring more about research, caring more about advocacy. And that's something that seems to be a little bit more differentiating than looking at the faculty groups.
Yeah, that comes with time and with experience as you move along your rotations and fellowship, you'll come to find what you really enjoy and the ones that maybe you don't enjoy as much. I was always afraid because I always liked everything. I liked all of it. And going into fellowship, I was like, oh my God, do I have to pick the left arm melanoma specialty? But that's not the case. So I wouldn't stress about it now, because I think it'll come. You'll figure it out as you go along. You'll know what you like and you'll know what you don't like as much.
And I think as some of us are going through the process and others have, the job market will also determine a lot of what you end up doing in your career. For some of us, it'll be what we want to do. For others, it won't be as much.
Thank you guys for that. So now that we're almost out of time, I want to thank you guys all for your amazing advice and answers to these questions and for your time for being here. And before I hand it over to Dr. Molina for some closing remarks, we just have one last piece of advice question. Is there any advice that we haven't covered or already been over that you guys have for aspiring surgical oncologists?
I guess I'll chime in, and I saw this maybe as one of the questions that was asked, and maybe we didn't address it. But when I first looked at surgical oncology, I thought it was this incredibly competitive field, and it's hard to get into, and you have to have all these publications and letters, and you get wrapped up in that whole situation, and you may doubt what you can do, and you may doubt your CV. But I think if it's really something you're interested in, do it. If it's, regardless of what your CV may look like, your AppSite scores, whatever it may be, if it's what you're passionate, as one mentor always told me, one door may close, but multiple may open. I think too, something you'll find as you go into any program, I think the question was about imposter syndrome. I think when you meet some of these incredible giants in the field of surgery, you're going to realize that they're just human beings who have errors, and they may not be as incredible, that everybody has this issue with imposter syndrome. And I think people can have that when they're trying to apply to surgical oncology. And so I think my advice is, be yourself. If you want to do it, go for it. Don't be dissuaded by, the situation. But I don't know, I think that's the advice I got, and I think it's worked out well so far. So
I'll add something else. Don't compare yourself to others as you go through the process. Everybody, as you've seen here, has had a different road and a different panel and different, essentially, application and CV. And as you go through the process, you'll be tempted to PubMed everybody you're applying with and look them up, and you'll see people who are amazing, and those are going to be your colleagues. but don't compare yourself to them because everybody has a different story and you contribute something different. So value yourself, be genuine, and just avoid comparing your crayons to your neighbor over there, and just appreciate the fact that you have something to bring to the table that is also very important.
I'll add probably also don't be afraid to take a quote unquote non-traditional path of I went into the lab, I did this. No, I never went into a lab. I was never a funded researcher and I'm here. And so, if you have different passions, if for me it's data and biostatistics, and still my mentors say, why do you want to be a biostatistician? I don't know. That's what I enjoy doing. And I do biostatistics for everyone. So if you have passions, if you have different skill sets, if you have an MBA, you can use that. And I think as Dr. Molina was saying, just make sure you can put that dot in your story when you're applying and say why that is valuable for whatever service. But different skill sets are important as well.
I would just add, it's a really great time to do surgical oncology. It's a very exciting specialty. When you see our attendings and even ourselves participating in multidisciplinary tumor boards and just demanding that knowledge of the evidence. And right now, when we're transitioning to precision medicine, and hopefully at some point to some precision surgery too, we're doing more palliative procedures. We're kind of breaking the rules a little bit more than just following guidelines, and the ability to generate new guidelines. I think it's just such an exciting specialty. And I don't see another specialty that has it all like surgical oncology.
Thank you so much. I'll go to Dr. Molina for some closing remarks.
Thank you, everyone. This was fantastic. I really enjoyed all of this, and so nice to meet all of you, future colleagues and colleagues right now. I would also add, enjoy the process, enjoy what you're doing right now. Be passionate, immerse yourself. It'll come across. I want to thank you all for joining us today. This is our second installment of Sowing Success. Cosechando, oh, I'm sorry, how do you say it in Spanish? Cosechando Éxito, there you go. We plan to have this series in the future to highlight various fellowship programs in surgery. I want to thank all of our participants who tuned in, our panelists, our moderator, Dr. Hernández. If you're interested in learning more about OSS, please look us up. We would love to have you as a member. You can look us up online at our website and also our various social media channels. And this recording will be on our YouTube channel. And if you can hear my son in the background, he's fighting to go to sleep. So hope you all have a good night, and we'll see you next time. Thank you.